Okay, so for those that don't know me, I'm Leigh Greenberg with Annie's Apothecary, compounding pharmacist and owner, and proud to be here in Boerne. I wanted to share this presentation with you guys. This is the exact presentation I gave about 2 or 3 weeks ago at the Texas Endocrinology Symposium in Austin. So it is geared a little bit more towards healthcare providers, but I'll fill in the gaps and explain it. It really is still basic information. What I learned from the responses of the endocrinologists is, unfortunately, there's still a long way to go with changing the standard of care in thyroid. It was eye-opening for me that that standard of care is still in the dark ages, in my opinion. So, but this is considered alternative, okay? Even though there are a lot of studies, it's still alternative. Hopefully someday it will become standard, but.
There's an arthritic doctor and specialist that helped me to figure out what I had. What was that?
Yeah.
It wasn't mine.
And typically we see better results in patients with thyroid disorders from primary care physicians, functional medicine physicians, and it really starts even with just what are you testing? I mean, it starts way up the line that the standard of care on testing thyroid isn't even where it needs to be, much less the treatment part, right? So we'll get into that. And obviously, I don't know everybody's medical history. This is being recorded, so once we do the Q&A, I can shut that off, and if we want to talk more openly, I'm happy to do that. But definitely, medical disclaimer, I don't know your history. I'm not treating you. This is all just general information that I think is important for you guys to know because you have to take care of your own health. But then, we can work with you. We do have really good physicians that treat Hashimoto's quite well. And so I can make those referrals later. So educational objectives, the first one is just looking at a full thyroid function lab test. What does that look like? And as a patient, you should always get copies of your lab results. It even goes back to the ranges of what's on a lab test aren't quite what they need to be. And so in a traditional practice, if you're not out of range, high or low, it's going to get overlooked unless that practitioner has the time and knowledge on what to look for. We'll compare conventional versus compounded thyroid replacement. Also establishing a nutritional support program for optimal thyroid function. And then just analyzing and treating thyroid autoimmune disorders using complementary therapy. Okay? So it's not always just giving thyroid hormone. There's other things you can do. So I know this is a little bit blurry, but you can see it in your handout. This is rudimentary physiology. So our hypothalamus so the pluses and the negatives. Plus means positive impact, and then negative is negative feedback. Okay, so our pituitary gland is where the TSH is. So TSH is typically what you'll see on your lab tests. It's actually an indirect measurement. Is TSH? It's called thyroid stimulating hormone. But just like it says, it stimulates the thyroid gland. So that's why you have the plus sign. So standard of care is to manage your thyroid by looking at the thyroid stimulating hormone. Okay? Because if you have enough T4 and or T3, it tells the TSH to go up or down. And that's it's kind of above the thyroid. So if you have enough thyroid hormone down at the bottom, it tells the TSH, it's a negative feedback and says, look, we have enough, slow down, you don't need to stimulate the thyroid, so that TSH number declines. If your T4 and T3 you don't have enough, it does that negative feedback to the thyroid stimulating hormone. Say, hey guys, recruit some more fellas. You need to kick that thyroid in here so we can make some more thyroid down here. So it's like this little loop thing that goes, okay? T4 is our inactive thyroid hormone. T3 is our active thyroid hormone. T4 has a longer half-life. It's kind of like your reserves. And T3 has a shorter half-life. And that's you don't need as much as the T3 because it's activated. But that's what interacts with your tissues and produces the response like metabolism, body temperature regulation, things like that. So the key is T4 has to be converted to T3. Okay? So let's talk about T4 to T3 conversion. Because like I said, this is really, really basic physiology, but if you understand that, then you can understand where the complementary therapy comes in. So deiodinase. So the 4 and the 3 actually means the number of iodine molecules on your thyroid. That's how they came up with it. So T4 is levothyroxine and T3 is liothyronine. But it has to do with the number of iodine molecules. So deiodinase means to take off an iodine. So you deiodinize it. So that's how you remove one iodine molecule to the next. So deiodinase is what causes that T4 to T3 conversion. I'm trying to make it understandable. And because I don't like to be a technical person. So anyway, so we have 3 different types of deiodinase, but ASE means enzyme. And so basically, deiodinase, it's an enzyme that activates or deactivates thyroid hormones. Okay? Oh, and you have this in here, so you don't have to squint.
Yeah. I had the wrong one. I didn't turn the page.
That's okay. Turn the page. I'll say ding next time you need to turn the page. I have children. I feel like I'm a teacher now. So there's 3 different types of deiodinase, and they're found in different parts of our body. So D1 is mainly found in the liver and the kidneys, okay? And it actually increases T4 to T3, so we're activating the thyroid, but it also degrades the T3. So it does that first part and activates it, but it also then inactivates it. Same thing, right? And then there's such thing as called reverse T3, which looks like T3, and it interferes with T3 absorbing and interacting with our receptors. So it also increases that. So T4 sometimes can get shunted over to reverse T3, but it also degrades reverse T3, so that's a good thing, right? Very, very confusing, but all these have different pieces. D2 is mainly found in the pituitary. Remember, we talked about the pituitary gland is where TSH is, and that's where most of our thyroid regulation happens, right there. So D2 is mainly in the pituitary. We also find in other parts like brown adipose tissue, heart, skeletal muscle. It increases the T4 to T3 conversion. So it activates the thyroid, which is what we want, right? Well, we also have D3. It's in all tissues except pituitary. Okay? And it increases your T4 to reverse T3. Remember I just said reverse T3 interferes with T3. They kind of compete with each other. Okay? So, what affects this D1, D2, D3? It's the D1, which we said was both positive and negative, right? It's kind of mixed, is decreased by stress, inflammation, weight, leptin resistance, diabetes, fibromyalgia, chronic fatigue, chronic pain, all of those things. So what does that actually mean? It means you have lower amounts of T3, which is the active thyroid, and higher amounts of reverse T3, which is competing with the active one, okay? So next part, D2, which is mainly in the pituitary, remember, is increased by chronic stress, inflammation, autoimmune disease, dieting and weight gain, so fluctuation of weight, diabetes, leptin resistance, all that good stuff. Basically the same things, right? So what does that equate to? We think it's a good thing, right? Because it results in more activated T3, but in the pituitary, okay? D3, same thing, increased by chronic stress, all the exact same things, inflammation, all the negative health things. That results in more reverse T3. So what does that look like? Happy pituitary, unhappy patient. This is when you get your TSH measured. It's in range. You have symptoms, and you're complaining, you have fatigue, you're depressed, you're losing your hair, fertility issues, menstrual issues, you're constipated, muscle pain, weakness, poor concentration. But your thyroid's normal. Your thyroid's normal, right? Because that's what the lab says. Your TSH is in normal range. Okay? So it could be true that levels of T3 could be sufficient in the pituitary part, which makes the TSH normal, right? But in the external tissues, it might not. But if all you're measuring is TSH, we have a lot of moving parts. How do you know? Okay? So this is what an optimal thyroid panel looks like. So like I said, always, always, always get a copy of your lab work. Become your own advocate, or go to someone who actually is looking at that and being your advocate. Okay? So TSH, yes, that's not going away. That's still standard of care. Oh, ding. Oh, not quite. Yeah. So the lab's reference range is 0.5 to 4.5. So the higher your TSH, the more thyroid your body says it needs, because it's an opposite relationship. The lower your TSH, it's suppressed, means you have too much thyroid and you need to cut back. So hyperthyroid. Okay? So even though this range is way up in 4.5, you're going to be symptomatic with all those symptoms we just talked about if your TSH typically is over 2.
Can I ask?
Yes.
You said the higher TSH equals more thyroid than the body needs?
No, opposite.
Okay.
Less. You need more thyroid.
You need
So it's opposite. High TSH means you have hypo or low thyroid. Low TSH means you have high thyroid.
Okay, so this is you need less.
Correct.
Need less.
Because your thyroid, because I think of the pituitary gland and the TSH as being a little army. So they recruit more people to go strangle the thyroid and say, hey, we need more thyroid down here at the bottom. But the less of those little army men that you have, then they're happy. The body's happy, right? But if there's only one person saying, hey, thyroid, you don't have to bug the thyroid as much because we have plenty. Okay, so, but we talked about all these other thyroid hormones. Why aren't those getting tested, right? They need to be tested. Okay, so T4, which is your inactive thyroid or your reserve, that's what you need. Your T3 needs to be tested, right? Because that's your activated thyroid. And what I really have people look at is, yes, it needs to be in range. Always shoot for the middle of the range. But at the same time, we talked about it's a conversion thing, right? Like windshield wipers. Well, our windshield wipers go like this together, not like this. And your T4 and your T3 should really be the same way. So we call it the thyroid gradient. And so if your T4 is straight up in the middle and your T3 straight up in the middle, you don't have any conversion issues. You're doing pretty good, right? But if your T4 is on the high end and your T3 is on the low end, that means you're not converting appropriately. So it's even more than just being in the range, okay? And then reverse T3, like I said, that binds to your T3 receptors and interferes with the activated thyroid. T3 uptake is really, in my opinion, not a useful measurement because it's a calculation. It's actually not measuring anything in your body. And you'll probably still see that on just routine thyroid panel. T3 uptake is a percentage. So if you kind of like what my mom or what I would tell my daughter, 100% of 0 is 0. But what shows up is 100% if you're looking at a percent, right? So same thing with the T3 uptake. It's saying how much percentage of your T3 is being utilized. But if you're supposed to have 10 molecules and half of them are taken up, that's 5. So it's 50%. But if you only have 5 and it's 50%, you only have about 2 molecules. So you would have those low thyroid symptoms. Does that make sense? So it's a calculation, is all it is, calculated by the lab. Okay. TPO antibodies is the really, really big one that tells you if you have autoimmune disease because it's antibodies attacking your thyroid. And that's how we have Hashimoto's. Okay. And so that's what indicates autoimmune disorder. You can't tell that typically with TSH unless you actually test it. And so it really starts with doing the right tests. And those are things you can ask for. Say, I really want to test this, especially if you have other symptoms. TSH is still a great screening tool. Great for screening. But if it's over 2 and you're symptomatic, you need to start digging deeper. Okay. Any questions so far? Anything you want to add? Okay.
So you said if it's over 2, you need to test the other things.
Yes, especially if you're symptomatic. Low thyroid symptoms of, coldness, slow metabolism, fatigue, hair loss, dry skin.
That's the key.
Yeah, all of those things. If you're symptomatic.
Symptomatic is the key.
Right, exactly. Okay, so let's look at conventional therapy. So conventional therapy is, ding, next page. Conventional therapy is levothyroxine sodium, which is T4. Commercially available drug, comes in a whole bunch of different doses, comes in micrograms, which is a very, very small amount. Typically, you see anywhere from 100 micrograms to 200 micrograms, and there's a whole bunch of different strengths in between. Okay, so that's good. We're replacing with T4. But what if you're the person that has the conversion issue and you're not activating that to T3, right? So yes, you're giving more T4, but you're still symptomatic, or your doctor's constantly having to adjust your T4 because you have things like chronic stress and you have these other things that are affecting the activation of that thyroid, okay? Oh, and it's also immediate release, so you take it all at one time. But it does take a while to convert, so typically you won't have heart palpitations. Liothyronine sodium is the T3. It is also commercially available. Some of the disadvantages with that, though, is it is immediate release, very, very short half-life, and as far as I know, it still only comes in 3 strengths. So you get 5, 25, or 50 micrograms, nowhere in between. Okay, the levothyroxine probably comes in about 12 to 20 different strengths, but the T3, which is the active thyroid, does not. Okay, and then there's also another one that's commercially available, Porcine desiccated thyroid. Some of the advantage of that is it contains both the T4 and the T3. Okay, so you have a little bit of both. It comes in a set ratio, though. So that's a disadvantage. If you need to adjust one or the other, you can't. You can only move them both up and down at the same time. Okay, it is a pig. It comes from pigs. So porcine, we've seen from a drug manufacturing perspective a lot of shortages over the time because it is considered a natural product. There are a lot more variations in it because it's a natural product. But a lot of times people have resolution of symptoms because they're given some of the active thyroid. You're not wholly depending upon that conversion. But it's not suitable. It's an anabolic product. So some people just, for personal reasons, religious reasons, whatever, don't want anabolic products. Okay, so that's something definitely that needs to be told to somebody if they're going to be taking desiccated thyroid. So let's look at compounded thyroid replacement. Customized dosages. We can make any microgram strength known to man. Okay, we can do a sustained release capsule, so that way it can let out that hormone over about 8 to 10 hours throughout the day, so you don't get the spike in a thyroid hormone. We can also do immediate release, so some practitioners like to do an adjustment. If they want to do a sustained release and then throw on a little afternoon dose, they can do that. I mean, it's completely customizable, okay, based on lab work, right? Lab work and symptoms. Okay, so one of the biggest things, and this is what I tell all physicians and patients too, is make sure your compounding pharmacy is potency testing. Because we're dealing with micrograms, you're starting out with very, very small amounts. So we use a 1 in 1,000 dilution. So for every 1 molecule of active thyroid, we have 1,000 molecules of filler. Okay, so we are able to purchase that product as is. They do all the quality control before they sell it to us, certificate of analysis. Sometimes that's not available, and we have to make our own. We will send, and we make a big batch of it, and so it's used for, maybe 100, 200 patients, right? We always send that off for potency testing before we ever put it in anybody's body, because we need to make sure that our potency for that big batch is 1 to 1,000. Okay, not all pharmacies are going to do that. It costs money. It's probably about $100 to $200 just to send off a little tiny sample to potency test it. Okay, so that's extremely, extremely important with any compounding pharmacy. Make sure the fillers that the pharmacy uses is not lactose, because that can inhibit thyroid activity. And then just making sure there's quality assurances programs in place. There have been reports that straight T4 instead of a dilution was used to make someone's thyroid, and it put them in the hospital, like 1 or 2 doses. It can happen. So. Okay, so that's enough background information, but it's important to understand kind of the basics, okay? So let's look at autoimmune disorders. 23.5 to 50 million Americans suffer from autoimmune disorders. And the reason why it's such a big range is depending upon the reporting agency. 23.5 million per the NIH, because they only have about 24 diseases that they attribute to being autoimmune. 50 million is the number according to American Autoimmune Related Diseases Association, because they have about 80 to 100 diseases that they contribute to being autoimmune disorders. It is the top 10 leading cause of death of all women. Women less than 64 years of age. Autoimmunes. Why women, right? Well, we talked about hormonal regulation, chronic stress, chronic inflammation, affects the conversion, right? All sorts of different things that are more genetic to us. So what are the causes of autoimmune disorder? Uncontrolled inflammation process. Because an autoimmune disorder, when you break it down, is when your immune system starts attacking itself automatically, right? So auto means self. But it doesn't just do that on its own. It happens over time. So leaky gut is one of the big ones, and then obviously just some sort of uncontrolled inflammation process. So how do we treat that, right? Obviously, just at the very top level, reduce inflammatory response, heal the leaky gut or intestinal permeability.
So how do you know if you have leaky gut?
So that's a great question. Let's look at it. Ding if it's the next page, but there's a nice little picture.
Not yet.
Here's a picture of what leaky gut syndrome looks like. So triggers causing intestinal damage, and then you'll go, oh, now I know why women have so many autoimmune disorders. Because you go down here, pregnancy increases the intestinal permeability, menopause, any type of food allergies, stress, blood sugar dysregulation, like I said, the weight gain, the weight loss, the yo-yo dieting, right? But really it's a lot of the hormones too. Low hydrochloric acid or enzymes, antibiotics, infections, a lot of different things can cause intestinal damage. You take an antibiotic and your gut microbe is all out of whack, okay? You're lending yourself to having intestinal and gut inflammation. So what that looks like, so if you get a mosquito bite or a hive, what happens? It swells up, right? It's red, it's painful possibly. But those cells, because they're so filled up, they swell. So your intestinal permeability, now you have the channels are bigger where your food is not digested down into the little proteins like it's supposed to. So here you have tight junctures, so things can't get through until it's broken down into the building blocks that your body can recognize it. When you have bigger holes, it falls through. And it's larger particles, and your immune system goes, oh, I don't recognize that. Let's attack it. Okay? And that's what our immune system is for. It's to protect ourselves from outsiders. Okay? So these are outsiders. These things that are just coming through the intestinal mucosal cells. So over time, our immune system, it's just like the TSH, right? The thyroid stimulating hormone. They go round up the army. Come on, we have an invasion of all these foreign bodies. Let's go attack them. Well, then eventually it lands in other parts of our organs. And that's where you get all the different names. There's a different name for a different autoimmune disorder based upon what organ is being attacked.
Oh, wow.
Okay? But it still goes back to it's autoimmune. So how does conventional therapy treat that? Y'all tell me.
I don't think they do.
The immune system is what's wrong. The immune system is overreacting, so we're going to suppress the immune system. Shame, shame, shame.
You quit going to the doctor.
Well, and that's not the answer either, right? But that's what people are given for autoimmune disorders. I mean, the disease tells you your immune system is the problem. Let's shut that down. Everything else. You basically wiped out your immune system. You need to calm down. And that means you're not available to help me when I really need you. When I get a bacterial infection or a viral infection or something like that, right? You're not around because I sent you to time out and you're not allowed to come out. Right? And I know that's like kindergarten bringing it down, but okay, so how do we fix that? So it's the gut, right? So we are what we eat, right? What we're putting in has the most profound effect on how our body operates. Not really sure why it's such a hard concept, but that's what it is. So things that we're exposed to in the environment that we absorb on our skin and things that we put inside of our body determines pretty much, yes, there's genetics and there's things like that, but what we do can turn those genetics on or off, right? So the 5 R's of leaky gut healing: remove, replace, repair, reinoculate, and rebalance. So removing is, we need to remove all these things up here as much as we can, right? We can't remove pregnancy. We can't remove menopause, but we can balance hormones, right? We can remove toxins, okay? We can remove food allergens, and that's really one of the big ones that we see, because remember I said that the biggest impact we can have is what we put in our body. And if we can't, we learn how to de-stress, okay? Blood sugar issues that come with food as well. Watching what we eat, infections, antibiotics, other drugs that cause it. So, low hydrochloric acid, because our digestion is not breaking down the food like it's supposed to, so we can add that on. So there's a lot of things we can do. So I already said all that. Okay, so replacing digestive enzymes, stomach acid, nutrients, because you're not absorbing everything like you should. Repairing that gut lining. So yes, but we still need to repair these cells. Okay. Yes, they'll regenerate on their own, but it'll be a lot longer, but we should help it. So we typically like to use L-glutamine or like immunoglobulins, different powders that help actually repair that at the same time as you removing all of the things that are causing it. And not probiotics. Put those good bacteria back in to help protect, be that first line of defense. Okay. And then rebalance. So lifestyle maintenance. Right? Because you can go through this and you can heal your gut, but it's not a healthy kick. It's not a kick. It's a change in your lifestyle, right? Because if you don't, the same things are just going to come back into play. So it's a lifelong commitment. So the food inflammation test. We are able to do that here with a finger prick, and it looks at the food sensitivities. Some of you might have already done that before. So the difference is an IgG versus an IgE response. An IgE response is typically an allergy or a histamine response. Like if you go to an allergist and they do like the skin testing, things like that, to see, oh, you're allergic, like you actually have an allergy to this. That's not what we're testing. We're testing just a sensitivity, meaning it's causing an inflammatory process in your body. So it's things you eat all the time. But it's the things that you know makes your joints hurt or your fingers swell, or you know what they are. You don't even need to have a test, because almost everybody knows, oh yeah, I mean, I know it's Mexican food for me, right? It's all the carbs or the gluten or, pasta. The next morning I can barely move my fingers because they're so swollen. That's what it is. I didn't break out in hives. I enjoyed it. I didn't have stomach upset, but it caused an inflammatory response in my body.
And you probably do it again, right?
Not as often, right? But that, right? So that's a choice I have to make. So how do you want to feel, right?
So the food sensitivity test via a finger prick test, does it tell you like all different kinds of foods? Or?
It does, and I'll show you what it looks like. Mm-hmm. Did you actually look through my slides before? So we're actually looking at the sensitivity, or it's a delayed response. So it's not immediate. Right? Like I said, I have Mexican food 6 o'clock at night. My fingers don't swell immediately. It's the next day for several days, right? It's a delayed response. So we're actually looking at IgG antibodies and antibody complexes. So it is affecting your immune system because you're creating an inflammatory response. So the big question you asked was, how do you know if you have leaky gut? So upregulation of zonulin is associated with increased intestinal permeation. So intestinal permeation is whenever you have those channels that are wider. Zonulin is something that we can test for. We don't always necessarily have to, but there are studies that zonulin is increased when you have intestinal permeation and you have leaky gut.
And so is the leaky gut test, the food sensitivity test, impacted by, like if you're taking curcumin?
No. Because basically what it does is it takes your blood, it shows the it exposes the food protein to your blood. At a cellular level, is that producing an inflammatory response? That's basically what it does. And this is what one looks like. Here's an example. A long time ago, I used to only do this with a blood draw, right? I have a 16-year-old daughter. She's now 21. At the age of 16 and a half, we did that blood draw. I was fortunate enough to have a relationship with a functional medicine physician that did those things. It was a lot more expensive back then. And we found out she had gluten intolerance and pineapple and some other things, but she was way symptomatic, like bent over, stomach pains, interfering with her life. But it's very interesting to me that it came on all of a sudden. She turned 16, she got her driver's license, she got a job, and she started eating at Taco Cabana twice a day.
Bad diet, so all those things.
Yes, all those things. Mainly the diet, just she flooded her body with gluten. She wasn't eating at home. She was on the run all the time. And then it got to where we couldn't figure it out because sometimes it wouldn't be right after she ate. You know, I tried to figure it out on my own before I asked anybody because that's what I do. And she would throw up 4 or 5 hours later after she ate. It wasn't immediately after. And it didn't matter what she ate anymore because she was so hypersensitive that everything caused a problem. And it just didn't matter. Okay? So we tested it. I also recently retested her with this particular test when we do our own internal investigations to make sure it's something we want to offer to our patients to see what it looked like on her. Because we did this with her and we did this with her. Gluten still shows up. She doesn't have gluten in her diet, but it still causes an inflammatory response.
So it's not saying that you have the response, it's just saying if you brought gluten in, you would show a response.
Correct. Right. And the red, I like the way it shows the severity. So red is the most severe and green is no reaction, right? So typically someone we can guess they have leaky gut, we see a lot of red. Because what happens is your body gets oversensitized to, like I said, everything is causing an inflammatory response.
And that would be like digestive issues.
Yeah, it could be a lot of different things. It could be fatigue. It could be depression. It could be joint pain. It could be gastrointestinal issues. Everybody presents differently because it's creating that underlying inflammatory response. Okay. And then I have other handouts bigger that shows everything. But this test, right, this test 132 different things. It's pretty inclusive. It also tests for Candida yeast, which is the bad yeast. Yeah.
Is that to poke with the finger?
Mm-hmm.
How much does that one cost?
This one is $325.
It's worth it.
It is worth, and I've talked to people. I was like, oh, that's kind of expensive. But then once I talk to people, like, well, it's taken them a year, and they're spending money here, 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 and here, and then we can do it overnight. Let's not guess. You can do food elimination. That's fine. Typically, people just wipe out gluten, soy, and dairy. We know those are the top 3. But what if you're a coffee drinker, my goodness, and it's causing inflammation? Right? And so these are decisions you can make. Okay, is that something I want to give up? Am I going to deal with the consequences of that inflammation? Is it just that one? You know, so you're able to go through that process rather than getting rid of gluten for 6 weeks. And that's the thing. Gluten stays in your system for about 6 weeks. So you have to be gluten-free before you even see if that was the trigger. But it's typically not just one thing. Okay? So celiac is not a sensitivity. Like, it's a you can't have gluten, period. Like, that's way higher. And that's not what this is testing.
People are running out and stopping gluten without even going.
Well, right, but because we know typically it is inflammatory because of the way, because there's so much in our diet and things like that. There's more gluten than there needs to be. Yes, ma'am.
I do have a quick question.
Yeah.
You're talking about that. So if you come, okay, I've done the test before.
Mm-hmm.
I'm not sure it's that one or not. Actually, I've done 2, and they both came back different.
Okay.
But I think
Same lab or different labs?
different labs, different doctors. And this one, right, I think this is the last one I did.
Mm-hmm.
And, okay, I came back with things that I don't eat that were up there. So from what you just said, that means, because they told me don't eat those things. Well, I don't eat those things anymore. I haven't had gluten in years.
Right.
And I'm like allergic to sensitive to 2 different kinds of gluten. The forgotten now what they
Like, I think it's the whole wheat, and then,
the
yeah.
other one. So I'm like both of them.
Mm-hmm.
But none of my stuff is red. I think orange or yellow is the worst. But
That's great.
yeah, and but they told me just don't eat it, and I was like, well, I don't eat it anyway. So basically,
It's not testing what's in your diet. It's testing how your body responds to these things.
That's why I just wanted
Right.
to make sure I understood you that that's what you meant.
Right.
That so all the time I just shouldn't eat that.
Or in moderation, though. So that's the other thing that people, but it depends on how symptomatic. Correct. Everybody's different. And that's why I kind of make very broad statements because everybody's different. Everybody's different, right? And if people a whole bunch of red, they're like, I can't eat any of those things. Well, right now, no. But let's heal you to where your body has a better response to these things so you can still enjoy them on a smaller, but we'll test it. We'll see.
So if you come back and there's no red and it's all just green, that means you don't have leaky gut?
It means you don't have food sensitivities.
Okay.
And since you don't have food sensitivities, you shouldn't have leaky gut either.
Okay, that's what
You're not having an
that's why
inflammatory
A,
response.
B, to
Yes.
C, but
Right.
it's A from C.
And I would think if you're symptomatic and you came back with nothing, something else is going on. But I tell you, we haven't seen one of those yet. Okay. And all of my employees did it themselves. In fact, I just did my 2 kids this week, and I'm so excited to see them. My other 2 kids, my little ones, my 9 and my 12-year-old. And so I did the full panel on my 9-year-old because she was a C-section baby. She had antibiotics first couple days of life. So that impacts your immune system from the get-go. From the get-go. So there's a lot of things you can't even change.
Because
Right.
I was on antibiotics for years when I
Right.
was little for ear infections. I mean, for years.
Right. And all those play into
It all
effect.
goes back.
Absolutely. Absolutely. So there's only certain things that you can control and change. Okay, so healing the gut. That's baseline. Okay. The other thing I want to talk about today is low-dose naltrexone. So naltrexone generally is a mu-opioid receptor antagonist. So I know. So that's the technical word. So what that means is it blocks opioids like hydrocodone, morphine. It blocks that on your receptor. Okay, so we use it for opioid overdoses in high strengths. So usually 50 to 100 milligrams naltrexone if someone has took too much opioids and you need to reverse it really, really quickly. Naltrexone will duke it out with the opioid molecule and knock it off so that way your patient can come back. Okay?
So low-dose naltrexone blocks opioids.
Naltrexone itself does.
Okay.
Right? Okay, just making sure you're on the right page. It can also increase endorphins. So endorphins are chemicals that make us feel good. Okay? And endorphins change the way the immune system responds. So you see how it's kind of progressive, right? Naltrexone, so antagonist means it blocks. It blocks, and it's all the technical words, but it blocks cytokine modulated immune system components. So cytokines are part of the inflammatory process. So it blocks part of the inflammatory process. Okay? So you see where I'm kind of going with this? It's helping with this inflammation that we've been talking about. And then it antagonizes production of NF-kappa beta, which it reduces inflammation in layman's terms. Okay? So, like I said, higher doses blocks the opioid receptors, but at higher doses, it doesn't have these good effects on the immune system. It's actually detrimental to our immune system. But a long, long time ago, I'd say probably 20 years ago, someone found out, well, if we do small amounts or low-dose naltrexone, we have all these positive benefits like boosting the immune system, endorphins, so it can help with pain. It actually has a completely different response when you use small amounts. And I'm talking about 0.5 milligrams to 4.5 milligrams. And now there's more studies with microdosing. I haven't even gotten into that. I'm going to learn more about that for chronic pain. Microdosing, like we talk about micrograms for thyroid, microdosing of naltrexone for people who are on opioids, because you don't want to block it off because then you could put them into pain, right? Because they're taking the opioids for a reason. So tons and tons of research out there. You had a question? Oh, okay. Okay. So that's why we call it low-dose naltrexone. Typically, you'll see it used is said LDN. Okay, that's kind of the short word, LDN.
And that is for healing leaky gut?
No, it is to help control the inflammatory process. Completely separate, but adjunctive or complementary to healing the gut. But we know even if you heal the gut, you're still going to have some inflammation. So this helps with the inflammatory process. So guess what? You can only have it compounded. It's not commercially available at low doses. It's only available at high doses, which has different uses. So you can only have it compounded. You can do capsules are the most common. You can do sublingual drops. You can do oral liquid, topical, even topical sometimes. But it's used in pretty much any autoimmune disorder. And there are studies for almost every single autoimmune disorder except Hashimoto's, which is interesting. There aren't any specific studies for Hashimoto's. But here's one. This is 2019, March. Low-dose naltrexone is a possible non-opioid modality for some chronic, non-malignant pain syndromes. And this is a hospice journal. So it's out there. A lot of people are saying, well, how can we use this? Will it help in our patients? And basically, the line I want to talk about is when used in doses of 1 to 5 milligrams, it has a neuroprotective effect. And it inhibits microglial activation. So it's inhibiting activation of the inflammatory process from 1 to 5 milligram dosing. Other modes of action include, opioid receptor blockade, which is what we talk about. It upregulates, which means it increases opioid signaling, which increases endogenous. Endogenous means what our body produces, opioid production. So basically, it's stimulating our body to relieve pain all on its own.
Oh, wow.
Crazy, right? At low doses, but at high doses, it blocks it. So I think it's really
I
interesting too.
discovered that accidentally when I cut a drug once that was I just wanted to, but I thought it was too much. And it was amazing.
It's interesting how dose dependent effects. Yeah.
It was
Yeah. So that's what's important. So basically, bottom line on this, low-dose naltrexone is gained full treatment, meaning it's not FDA approved for these indications. No drug company has actually, they're starting to catch on. Off-label treatment of several autoimmune diseases, including MS, multiple sclerosis, bowel disease, as well as chronic diabetes. These are all the pain things. But we know pain is associated with inflammation, and we know the process, right? And so theoretically, it should help with people who have any autoimmune disorder because we know it's created from inflammation. Hashimoto's is an inflammatory process because our immune system is attacking the thyroid. Okay? So you kind of go upline and use what you know and try it, right? So let's try it. How does LDN help? Well, like we said, under chronic inflammation, stress, pain, autoimmune disorder, diabetes, you have hypothyroid, typically. You could have hyperthyroid, though, but you have dysregulation of the thyroid. So LDN reduces pain and inflammation that may allow that T4 to T3 conversion to improve, right? Because all of the chronic stress and autoimmune disorders blocks that activation process in the thyroid. So Hashimoto's dosing, you would start with about 0.5 milligrams, so very, very low, because we don't want to overshoot it, right? Because 0.5 may work for you, 1.5 may work for you, 4.5 may work for you, all for the same disorder, right? So you start low and you work your way up. You increase it every 2 to 4 weeks. Typically, the biggest side effects with LDN is vivid dreams because it increases the endorphin release. So we think that's what it's tied to. So we move it to a morning dosing. And people typically know when that tilting point is. So let's look at an actual patient. Oh, actually, not yet. So here's just a quick example treatment protocol. Month 1, remove all your foods with the 3 and 4 plus reactions like we talked about. Liver detox. This is what we like to use is this little detox pack that has things like alpha lipoic acid in there. It helps support your liver. A lot of anti-inflammatory supplements. Yes, ma'am.
What if you can't do the alpha lipoic acid?
This is just a convenience thing. So this is just an example. We customize everything to each person. Yeah. Begin your lifestyle modifications because those are new habits you're going to have to form. Okay. Month 2, let's add on digestive enzymes. You can do one with every meal to help break down those foods while your gut is healing. You can also do it on an empty stomach. It helps with inflammation on an empty stomach also. Hormone testing and balancing, because remember we saw menopause has an effect, so making sure that the hormones are balanced. L-glutamine is a really good one to help heal the gut. And then LDN would be indicated if there's an autoimmune disorder going on. Because not everybody who has leaky gut has an autoimmune disorder. Like, it's not like that. It's not, if you have leaky gut, you have an autoimmune disorder. But 99.9% of the time, if you have an autoimmune disorder, you've got gut issues. So it can go the other way. Month 4, probiotics, and I out in different months because it's overwhelming. It really is overwhelming, and so it just depends on how dedicated you are, and everything costs money. So we look at that too to try and figure out what's the best to fit a budget. And then month 5, slowly reintroduce the foods, consume it in moderation, assess your symptoms. LDN is something I would keep on forever because you always want that baseline help with inflammation. Okay, so here's our example patient. So June of 2018, this patient had a TSH level of 0.5. So what does that mean? So she had too much thyroid or not enough thyroid?
She needs more.
She has too much. Because remember, it's opposite. The lower the TSH, the higher your thyroid have. So it's opposite. So you're hyperthyroid. Thankfully, her physician tested TPO antibodies, 568. She should have less than 9 is normal. 586 TPO antibodies. Typically, range, TSH is 5 to 4.5, you're in range, right? But they tested their TPO antibodies, tested the estrogen, progesterone. The diagnosis was postmenopausal with hyperthyroidism with Hashimoto's because of the TPO antibodies. Okay, so she was hyperthyroid, her TSH was suppressed, and she had TPO antibodies.
So anything over 9 means you have Hashimoto's on the TPO antibodies?
Yes.
Wow.
Treatment plan. Well, I mean, you'd have high. Yeah. So the treatment plan. This person didn't even do a food sensitivity test. I mean, she just did right? With some probiotics and digestive enzymes. So she started all of that, and no medications were given. Okay? Nothing was given to stop the thyroid from producing too much. A lot of times that we see that, the thyroid is acting up. Let's stop it. Or let's take it out. Okay? None of that happened, which is good. So just gluten-free, dairy-free, soy-free diet. So June, July, August. 2 months later, estrogen and progesterone was started because she's postmenopausal. She basically had no hormones, none. But we didn't start it all at once. And not we. The practitioner managed this patient. We filled the prescriptions, and this is all patient reported. Okay? Started estrogen topically, orally. In December of 2018, so 6 months later, her TPO antibodies were tested again. They fell to 305. It's amazing. That's a huge drop with diet alone, right? Patient reports losing 10 pounds, feeling better with increased energy with diet and hormone replacement alone. That was it. Okay? So April 2019, a Dutch test was done by her provider, which is a dried urine test for comprehensive hormones. That's what Dutch stands for. It did show elevated cortisol, so that means stress, and suboptimal estrogen progesterone levels. So even though she was taking hormones, it wasn't enough. Okay, so this is what the plan was then. Week 1, adaptogenic herbs to help normalize that cortisol, because remember that's a risk factor of our leaky gut. Drops, adaptogenic herbs, ashwagandha, licorice root. There's a variety of different ones. Week 2, the estrogen was increased, and then week 3, progesterone was increased, and then week 4, DHEA was added on to support the adrenals. Okay, because a lot of times when you're stressed, your DHEA levels become depleted, so you can add that on. So June 2014, she started LDN. So she started 1.5 milligrams at bedtime. If I would have made recommendations, I would have started her lower. especially since she did have side effects. She had the vivid dreams. She at night, she just wasn't sleeping well. So I think if we would have started her lower, it would have eased her into it, and we wouldn't have had those profound effects, and it would have been a little bit more tolerable. So she ended up switching it to a morning dose, and that alleviated that. July 2014, her practitioner doubled it. I wouldn't have gone that fast either, okay? Because she was feeling good on 1.5. But if you're good, can you feel better, right? 3 overshot it. And, when I made this presentation, it was just right after July. I gave the presentation first week in Austin. Patient reports this process has been life-changing. She has seen continued weight loss around the belly and occasionally mild symptoms of malaise, which is like fatigue, compared to daily fatigue and flu-like symptoms. So on paper, it looks simple, right? It sounds simple, but it's a process. Okay, so I followed up with the patient. 3 milligrams was too much. She kind of overshot it. So we're going back to what we know, 1.5, see how that does, and then maybe we'll add another 0.5. Maybe 1.5 is good for her. But Hashimoto's, we're seeing that 4.5 for the most part ends up being too much, even though that's typically the highest point of what's considered LDN. But Hashimoto's patients seem to do better at 2. So, this is a JAMA article, which is Journal of American Medical Association. Very well-renowned journal. This is like the Bible for the healthcare professional. So October 2018. The title says, Association of Thyroid Hormone Therapy with Quality of Life, because that's what's really important, right? Quality of life. Those are your symptoms and how you feel. And thyroid-related symptoms in patients with subclinical hypothyroidism. So what subclinical means is their TSH is in range, right? It's probably between that 2 to 4.5 that we talked about, but they have symptoms. And so this was a review of a whole bunch of different studies with those type of patients. And it was non-pregnant adults, so we took out the pregnancy component. So subclinical hypothyroid. It says, conclusions are, among non-pregnant adults with hypothyroidism, the use of thyroid hormone therapy. So they were given thyroid to get their TSH lower, okay, because that's what standard of care is. It was not associated with improvements in general quality of life or thyroid-related symptoms. So they gave them thyroid. I'm pretty sure that's the only thing that they did. But we've seen that you can do other things to help improve that, right? These findings do not support the routine use of thyroid hormone therapy in adults with subclinical hypothyroidism. So what I ask myself is, A, what kind of thyroid was given, right? What was the ratio of men and women? It might be in here. Ooh, actually, it's not. Just 2,192 adults. How many women were in here? We don't know because it didn't say, right? Did these people have conversion issues? Were they even converting? Did they have leaky gut? Like, there's so many other things. But endocrinologists know that just because you get thyroid doesn't mean you get better. There's a lot of other things. You're still unhappy. So, food for thought, right? There's more to the hypothyroidism than just giving thyroid. Okay. That's all the information that I have. Like I said, overview. It's food for thought, things to look at. You can kind of go through your medical history and, take charge of your labs, ask the right questions, things like that. We do work with a couple practitioners that we actively refer people to, especially with LDN.